I'm sure that everybody has seen a tracing that looks like this, and you cannot possibly interpret all these scratches. So you really need to make every effort possible to correct it. And be sure to document what you did to improve the quality of the tracing. And nursing should consult as well with your primary care provider to suggest maybe enhanced monitoring. So if you're really struggling with getting a good tracing that you can interpret, then maybe you need to suggest that an internal fetal electrode be used or intrauterine pressure catheter. You don't want to just let it go on and not respond to it. So one of the things we just wanted to draw everybody's attention to, we talked about the frequency of assessments for IA, and for EFM, it does again just depends on the stage of labor. About every 15 minutes when the mother's in active labor, every 15 minutes if it's a passive second stage. But the big change is that you just have to do the documentation every 15 minutes if it's active second stage. As long as there's a continuous interpretable tracing and that there's a caregiver present, then you can just document every 15 minutes. And this gives the nurse time to support the mom and to help with the pushing. But if you're having any trouble, then you're going to have to increase that frequency of documentation to every 5 minutes. This is one of the tables that is really great. Summarizes the frequency of the assessments, including the maternal heart rate and when they should be done, and IA and EFM as well.
So this is the table that is kind of like everyone should have at the bedside, and it's very similar to what we had before. We've added the uterine activity. As you know, you can have tachysystole with a normal tracing, tachysystole with atypical tracing, and tachysystole with abnormal tracing. And that really helps in communication, because if you have tachysystole with an atypical tracing and you're running oxytocin, you're simply going to just reduce the oxytocin. You won't be calling for an emergency. And so that's communication can really help that. The baseline hasn't really changed. A mild bradycardia, 110 or less, it makes it atypical. It's important to know that the only time there's a 30-minute duration is when you're talking about tachycardia. So greater than 160 for 30 minutes makes the tracing atypical. If it's greater than 80 minutes, it becomes abnormal. A rising baseline, just like for IA, is a concern, and that makes it atypical. And we put in arrhythmia, because in the old guideline, it wasn't classifiable. Like you had arrhythmia. Well, where does it fit? Well, it fits with atypical. And certainly, if you've got a substantial bradycardia or tachycardia, you're going to, an erratic baseline, that's always important to know when you've got a good quality pickup and you can't determine the baseline and it's all over the place. That may be associated with acidosis, with instability of the cardiovascular system. So that's erratic baseline is a concern, just like marked variability is in a situation where the fetus is otherwise not showing you well-being. If you have marked variability, that is abnormal after 10 minutes. But anyway, more about variability, same things that we talked about before, is that the important thing is that minimal and absent variability means the same thing. So when you're teaching this, if somebody says, oh, is it minimal or is it absent? You know what? It doesn't really matter, because all the criteria mean the same thing. So minimal variability makes the tracing atypical after 40 minutes and abnormal after 80 minutes. But as I said before, variability may be caused by a whole bunch of stuff, including, as you all know, analgesics, betamethasone, antihistamines, many drugs. So always you have to classify the tracing, but then interpret it. Again, what is the reason? Accelerations are important, and we've clarified them that they're not necessary for a normal tracing. They can be present, but they're not necessary for normal tracing. And the other thing is that if you have an otherwise atypical or abnormal tracing, if you have a spontaneous acceleration, it doesn't change the classification. It can be used when you think about your interpretation of that tracing. So if you have, let's say, recurrent late decelerations, but moderate variability, and maybe even a spontaneous acceleration, you're going to look at that and say, you know, let's interpret this. This may be a fetus that may not be compromised, that what we're seeing is just some short-term acid-base changes that it's managing. So accelerations need to be considered, but don't change the definition of the tracing or the classification. And decelerations, we talked about repetitive, uncomplicated variables making the tracing atypical. You can have non-repetitive, uncomplicated variables and have a normal tracing, but once again, if you have repetitive, non-repetitive, uncomplicated variables that are more than just occasional, you may want to be concerned about that in early labor. Intermittent late decelerations make the tracing atypical, and we talked about the repetitive complicated variables and recurrent lates making the tracing abnormal. The same approach to these as the old guideline. Normal means carry on, support the woman, be aware of the changes. Atypical means vigilance. What's happening? Put it into context. And then abnormal means interpret and then respond. I think it's important when you're doing teaching to kind of give people an idea of what normal gases are. And I always emphasize that this just is a really good reminder on how good that fetus is to manage the physiologic challenges of labor. I always ask people, what is a normal fetal pH before labor? If you did a cortocentesis before labor, and it's 7.4, just like you. But the baby in labor compensates. And so, and then I say, how would you feel at 7.27? And they say, well, not very well. So again, it's really important to emphasize that the fetus can compensate for a lot of reasons. And one of the things that we have in the course is a lot of talk about what are those elements. And then we recognize that we consider an acidosis at 7.20. PCO2 should be under 60 or so, and bicarb more than 18, and a base deficit of 5.5. I think when you're talking about base deficit, you always have to remember that's a calculated amount. And once you have a very high PCO2, the numbers don't make any sense. Because to calculate base deficit, you kind of calculate the amount of base you add to make your pH, your PCO2 back to 40. And that means that when you can have actually an acidotic baby that can have what looks like a normal base deficit. That's complicated, but just to be aware of always look at not just the pH and the base deficit. Okay, this is really important, is that resuscitation means you're going to do a lot of things, including speaking out loud, informing the woman or her family, and making sure everybody in the team is aware of what you're doing. The first step is, of course, changing her position. If she's lying on her aorta, she may not perfusing her own plus the fetus. You're going to assess her vital signs, her heart rate, very important. Maintain optimal blood flow. Obviously, if you're running oxytocin, you're going to stop oxytocin to give the baby a chance to recover between contractions. And in the case of tocolysis, if you're running either oxytocin, usually that'll settle down. Oxytocin's half-life 6 minutes or so. If you stop oxytocin, it's usually cleared within 1 or 2 half-lives, unless they have a bolus. But if you're using prostaglandins, think from misoprostol to the others, you may want to consider IV nitroglycerin, and it's always important to have a nitroglycerin kit or some information on how you give it, because it has to be given IV. One of the things, though, is that really important in the second stage is that often there's an abnormal tracing, and you've probably all seen this, where there's a tracing of prolonged deceleration or complicated variables, and everybody's yelling, push, push, push. Just stop pushing for a couple of contractions, and it's remarkable how well the fetus can compensate. Remember that when a woman is pushing, intrauterine pressures are way more than 60. They can be 100 or so, and there's no perfusion unless there's some time for that fetus to resuscitate itself. So modifier, stop pushing, will often save the tracing and make the tracing improve. We really emphasize importance about not giving a fluid bolus unless the mother's hypovolemic or hypotensive. And especially in cases with preeclampsia, you can cause a lot of harm if you overhydrate her. She third space the fluids out of her vascular system. Obviously, you're going to do a vaginal exam to assess. Maybe the head's crowning, but maybe there's a cord. If you've got complicated variables, amnioinfusion can be very useful. You're going to support the woman and family. And we haven't changed from the old guideline where you're only going to use oxygen if she's hypoxic or hypovolemic. As you know, oxygen can do harm if her oxygenation is adequate. These are some of the things that gives us some information. Spontaneous or induced acceleration can mean that the pH is 7.20 or greater. It's useful, and you can rely on it to some extent. Fetal scalp sampling is hopefully going to be something we'll have more access to, and we now know that lactate, of course, requires much less. It can be a bedside monitor, and we do address this in the guideline a little bit, and some places are using this, and I think it's something to keep attention to.